Welcome to everybody to the FTD support group meeting run by Rare Dementia Support. Welcome to those that have been coming along for many years. Welcome to those that are new in the last year, and welcome to those that this is their first meeting. My name is John Rohrer. I am a professor in neurology at the National Hospital for Neurology and Neurosurgery. I have had an interest in this condition, FTD, for a long time and help run this group. Quick reminder, although we're online today, we will be back to an in-person meeting for our next meeting, which will be in March, our annual seminar. So please do come along. I know there's lots of benefits to having our online meetings, but it's good to be able to meet in person, and obviously there's if you can make it, you get to see all of us in person, but also more importantly meet people in the same position, and lots to be shared. On that note, we have been running now for a little while a monthly peer support group for carers of people with FTD. If you would like to be part of that, and it's a really great group, really growing, and I know lots of people have found that really helpful, then do just drop us a line to the usual email at Rare Dementia Support to become part of that. Another quick reminder that we have another group for people that have the language form, primary progressive aphasia, and also a group for people, particularly family members who have a genetic form of FTD, or FTD group. Again, if you're interested in those groups, just drop us a line by email. So today we're going to focus on thinking about the times of transition. So for many of you, when you first get a diagnosis, a lot of the input needed from support services, and whether that's us or others, is understanding the diagnosis and the pathway forward. But sometimes it can be hard to know when one needs to ask for help, or what one needs to ask for. So our team today are going to try and talk through that, and I'm going to hand over to start with to Nikki, and Nikki's going to talk through when do I need to ask for help. Nikki.
Thank you, John, and hello everybody. It's really lovely to be here with you today. And the first part of our session today, me and Livvy are going to speak about asking for help, and then continuing on from us, Claire and Trish from the direct support team as well are going to look at sort of different parts of later on sort of in the diagnosis. So I hope this is going to be some helpful tips for you out there. And it's not exhaustive. It won't apply to everyone. We do know that FTD affects people and families in very, very different ways. So, you know, we always are available to speak to on the telephone, to email, to do Zooms, to talk about your own personal situations, but hopefully you'll take a bit from that today. So Livvy, I think this is like one of our major questions that we have, isn't it?
Absolutely, absolutely.
It's something that we talk about in our weekly meetings all the time, of, you know, getting people to accept some help. And it's certainly been a question sort of that comes up in the peer support groups all the time. So asking for help, what I actually want to sort of really bring up here now is to rewind a little bit. And it is something that I know a lot of carers, I know it within my own family as well, asking for help. And Livvy, you're very aware of that within your family and circle as well, asking for help. There's a bit of a stigma to it. It's a bit of like, no, I'm coping okay. I don't need to ask for help. But let's rewind sort of a bit before sort of you even went to the GP, and sort of talking to you guys out there. Some of you are family members, caregivers, and some of you are living with the diagnosis as well. And before you actually actually went to the GP, you noticed that there were some problems there in the beginning. There were some issues, life wasn't quite as it was. So you've actually taken that big step already of actually admitting that there are some issues and needing some help with those issues. So you've done that big step of going to the GP. I'm also very aware that, and we talk about this a lot in the support group meetings and our meetings as well, is you may have gone to the GP a few times. You may have not been listened to from the GP. Oh, my slides have gone on. I'm not sure why. Thank you. So you may have gone to and visited the GP a few times and had that conversation. And it may have taken a little while before you actually were taken seriously and gone on to the next step of being referred to the community mental health team, the memory assessment service, or to a neurologist. And within that process, you would have spoke to the clinician, you would have identified sort of some of the issues that you've had. And by identifying those issues, you would have asked for help for them, get some understanding, whether it's making sense of what's going on or what happens with this, where do I go next? So already you're reaching out for help and you're asking for that. So although you possibly haven't sort of thought yourself this is what part of the process is, it really is, it's already started for you. And then once you've got that diagnosis has been made sort of clear, or even before that, you've contacted us at Rare Dementia Support and you've asked us for help, for strategies, for tips, for some education of where do I go with that. So, you know, you have already made those initial steps of recognizing we need some help here. It can also be quite difficult because we know one of the major symptoms of FTD is lack of insight. So when you're asking for help after going through this process and realizing you do need some extra help to come in now, it may differ of where that support needs to come to. Because if you're looking after somebody who has very little insight, it might be difficult for them to accept any help and support. So what we're going to do now is Liv is going to talk through the issues within these situations. Over to you, Liv.
Thank you very much, Nikki. It's really wonderful to be here live today, chatting with you all again. I'd like to quickly touch on, as Nikki said, symptoms of lack of awareness. And this is something that the carers of people living with FTD often do contact the direct support team about. And I feel we often mention lack of insight and awareness briefly in lots of our talks, but we've not perhaps explored it deeper at an RDS webinar. So more specifically on this slide, I'm going to be talking through anosognosia, which is a very fancy word and very difficult to pronounce, going through what it means and describe some ways to manage lack of awareness. So first, what is anosognosia? It's defined as the inability to recognize or perceive one's own limitations. So this can be your abilities, illness, and also it's known as lack of insight. And it's a very common symptom of behavioral variant FTD. And some researchers even suggest that lack of insight is the single most important reason why people living with FTD do not seek professional help and may also engage in risky behaviors. So, for example, driving when they're not safe to do so anymore. So there's two main types of anosognosia. The first being cognitive unawareness, which affects memory, spatial orientation, calculation, and abstract reasoning. And the second, behavioral unawareness, which is commonly seen in people living with FTD, with things such as irritability, inappropriate emotional displays, and sometimes disinhibition as factors there. So how does loss of insight affect carers? So a person living with FTD who has this symptom is unable to recognize that they have an illness and that their abilities have changed. And it's incredibly important to remember that this is not denial, but rather than the result of changes in the brain with people living with dementia. And so we need to accept that this loss is more than just denial. You cannot persuade a person living with FTD who has symptoms of anosognosia that they have a problem. It's part of the brain for reasoning has been affected by this dementia. And of course, this can be incredibly concerning for family members and friends, but the person with dementia may be relatively unconcerned. So lack of insight may present as the person being resistant to care needs, to help, and the person might appear perfectly normal to other people, including healthcare professionals. As Nikki's mentioned, it sometimes takes a lot of GP visits or visits with healthcare professionals to be heard. And family members may believe that the person with dementia is lying. So moving on to strategies. First, and I understand it is extremely difficult and it doesn't come overnight, but acceptance. Understand that explaining and reasoning aren't going to be progressive in this situation, and that lack of insight is due to FTD. Patience, so recognizing why as a caregiver, you're asking for certain things, asking certain questions, and ask yourself, is it important? And if so, why? You may want to develop alternative reasoning for achieving a goal, such as if somebody is resistant to bathing or showering, having a valued activity. So for example, if you know that that person really values seeing their children or grandchildren, having that as a reason to engage in a task previously. And this is something that myself and the direct support team are very happy to chat further about in one-to-one sessions. Supervise for safety. So for example, behaviors relating to FTD, sometimes this could be insight into money and spending. So if you're finding that someone's spending lots of money on items, that person might not have insight into that value of money or spending. And this also might tie into obsessive behaviors, which again is very common in FTD. And I've chatted about obsessive behaviors previously on a webinar, which is available on the YouTube channel if that's something of interest. Have lasting power of attorney in place for both health and finances. Two of them, two lasting powers, health and finances. And this is something that the entire direct support team agree should be done as soon as possible, as soon as it's right for your family. And then finally, speak about strategies. So from apathy to sexual symptoms, the direct support team and I are happy to have one-to-one conversations on behavioural strategies that may work for you and your loved ones. And I'm going to pass it back over.
Thanks, Livvy. Some great advice there. We're going to talk about support now. And as we always with people that come to us, we talk about having assessments for support, because these are sort of things that are going to identify needs and what's going to help you. And there's two forms of assessment which the local authority carry out. And the local authority are there to do social care. They're there to identify needs and provide support or provide provisions of support. Sometimes you will have to pay for these aspects of support, but they'll identify people's needs. And a needs assessment is for the person that's diagnosed with a dementia, and the care assessment is obviously for the carers. Claire's going to talk more about this a bit later, but just want to sort of to point out, if somebody has very little insight into what their issues are, it's going to be very difficult to have a needs assessment, because all the questions that the social worker is going to ask, they were going to answer without identifying any needs, because they don't feel they have any needs. So this is where we sort of look at, let's get a care assessment involved, because then we can look at what the needs that the carer actually has. And it's something that you can think about yourself of, how do I make my life a little bit easier? What do I need? Because I might be exhausted. I might really need some help there. And I know my loved one may not want any help or feel that they need any help. So it's actually my needs which I need to identify. So do I need some respite? We know with some of the aspects with FTD, behaviour variant FTD, can be really quite exhausting. The compulsions, the excessive spending, the excessive eating, constantly on the go, full of energy. So it might need that you need a break yourself. And that respite can be having somebody round to spend some time with a loved one, companionship, or even as far as actually having a few days, a few weeks break as well. Help around the home. You might be very busy as a partner of somebody living with FTD who's got a really varied activity schedule on, because they like to keep busy and you like to keep them busy. Active minds, really good, but it might be exhausting. So you might actually need somebody to come in and do the housework while you're busy going to singing for the brain, sports events, theatre groups, museums openings, goodness knows what. So, you know, it might be an idea to get someone to come and help around the home while you're doing that. Or it might be that you might need a companion to go and do those things with your loved one, so you get a bit of a break, so you can get to do the things that you want to do. Go out for coffee with your friends, have a nice long lunch with the girls, go and see your grandchildren on your own, those sorts of things, you know. So it's something that really you could look into, that actually, although you could be employing a PA or a befriender to be with a companion with your loved one, that's going to be a great sort of anchor of support for you. Or perhaps it's a shopping service. Perhaps it's really difficult going to Sainsbury's these days because all that goes into the trolley is ice buns and bars of chocolate. Or perhaps there's, you know, that impatience at the tills, or perhaps that inappropriate behaviour going on. So perhaps it's a shopping service that's going to be there to help you. So although these things are support which fundamentally are going to help you, it's also there helping you live more happily without too many complexities and confrontations with your loved one with FTD. Back to you, Livvy, now.
Thank you very much, Nikki. Lovely. So not everybody living with FTD has anosognosia, has lack of insight. So living with FTD, what will help? What will help you? The first thing I would say is getting information. So understanding the disease's overall progression. This is really going to help you approach ways to stay active, engaged, informed about services, informed about support, and even research opportunities that may help improve your quality of life. The next thing, and I think that this is extremely important, is advanced care planning. Many people living with dementia fear losing control and not being able to make their own care decisions. Discussing advanced care early as possible can avoid that. So a reminder what these are. So an advanced decision, also known as a living will, or an advanced decision to refuse treatment, is a decision you can make to refuse a specific treatment in the future. Now, an advanced decision is legally binding as long as it meets certain criteria. So a decision you can make to refuse a specific treatment, and that's legal. Meanwhile, an advanced statement is a written statement that sets down your preferences, wishes, beliefs, and values regarding your future care. And this could include how you want any religious or spiritual beliefs to be reflected in your care, where you'd like to be cared for, whether this is at home, in a hospital, a nursing home, a hospice, how you'd like things to be done. So if you prefer to have a shower instead of a bath, if you like to sleep with a light on, and practical issues. So for example, if you were to take ill, who would look after your dog? And it's important to remember that an advanced statement is not legally binding, but anybody who's making decisions about your care must take this into consideration. And it's very, very important to keep it up to date. If you've got one of these advanced statements, please do remember to keep it up to date and update things if things do change for you and your family. And this ties in nicely to my next point here, which is finding support. So first of all, knowing which professionals are there to support you. So that is your GP. It could be an occupational therapist. It could be a speech and language therapy team, could be a community mental health team. And of course, all of us here at the direct support team and Rare Dementia Support. Living with FTD can be very isolating. And this is why it's critical to create a social network, social, emotional, and practical support for yourself. And the direct support team can assist you in making these connections through our peer support groups for people living with dementia. And stay connected. So now that you've found RDS, you're here because you've contacted us, that you've signed up to our mailing list. Let's stay connected. We do send out newsletters, we send out research opportunities, we send around updates and invitations to the webinars such as this one. And we are always available for one-to-one support for a range of different issues. And finally, a last thing which I wanted just to briefly talk about is about awareness cards and sunflower lanyards. So these are a very easy way to let others know what FTD is and how this might impact your behavior, perhaps in a public setting, or that you need some extra assistance. The sunflower lanyards, which you may have seen, are now recognised across a huge range of sectors. So from retail, financial services, transport, including airlines and airports. You do get some extremely good VIP treatments in airports with the sunflower lanyards. They're noticed across the UK railway network, supermarkets, emergency services, and so much more, so etc, etc. So they really are worth having. And I'm now going to pass this on to Nikki.
Thanks, Livvy. Thank you. And just to sort of let you all know out there, me and Livvy do work very much together, and it's a very joint approach here. I'm beginning to feel a sort of good cop, bad cop of like me sort of going through the carers and Livvy doing some sort of aspects with those with the diagnosis. So we did work this out together between us. So we are very joint with our support for everyone and very inclusive. So I just want to put that out there for you all. But I think, you know, we've brought together quite a few sort of things which we hope that, you know, you can all take forward and share with your family and friends as well, to sort of to have those discussions of how you can all be supported together. I mean, there's individual support, but family support is really, really important. So there's full on understanding. So sort of moving forward, where are we going to go from here? We've spoke about sort of first steps of how far you've come, and not sort of, you know, dismissing that, really acknowledge that of where you've already sort of put yourself out to look for that help and what you've got in place already, because that's really important. You've taken those first steps, we've given you some advice, and hopefully all of you out there have had a call with us at the support team. But if you haven't, please, you know, do email us and get in contact with us, because we can really, really help in your particular circumstance. And we can help you with having those first steps to increasing the support that you'll need going forward. You know, this will, as Livvy says, this will always need updating. Things change. And what we want is you to have things in place to meet your needs as you go along. Now, we're going to be going on to Claire and Trish to speak in a moment. But if you've got any questions on what me and Livvy have been speaking about, we are going to have an extended Q&A session in the end. John will be joining us for the Q&A session. And we know this is always really, really popular. And when we had our in-person seminar, which was fantastic back in July, I know John wasn't able to be there at the end of the day. So, you know, if you do have some questions for John, this is going to be a perfect opportunity today. So please put them in the Q&A box. The chat box isn't working today, the Q&A is. So please do put your questions in for John, for me, Livvy, Claire and Trish, anything that we're talking about, or anything that comes into your head, which is really important for you. I'm going to hand over now to Claire and Trish. Hopefully they're going to jump on the screen so we can see them. So I'm going to leave you with these lovely ladies, and they'll talk you through the other part of the journey, which some of you may be in, some of it may be in the future for you, but some really, really important advice coming your way. So I will leave you with Claire and Trish.
Okay, thanks, Nikki, and thanks, Livvy. That was great. We're thinking about when people have been diagnosed with FTD, and really, I suppose this is looking at the journey across all the support. So we're moving forward a little now. A lot of people last a long time with very little support, and none sometimes for a long while. But once they start needing support, they start looking for it out there, as Nikki and Livvy described. So I'm going to ask you now, Claire, really. And the situation can get a bit worse. You might have a befriender, you might have somebody who's coming in maybe once or twice a week to go for a walk with the person living with FTD, but you're finding yourself more stressed, more worried, and you need more support. What do you do next?
Thanks, Trish, and thanks, Nikki and Livvy, for covering that really helpful information about the first steps to take in terms of support. This is a really good question, Trish, thank you, and a really important question to cover, because we know that people living with FTD have changing needs over time, and it can be really difficult to predict these changes. And it's really important to look at increasing the care and support that's in place as things change as well. We're just going to have a little bit of a chat through some of the things that might be helpful to have a think about if things are becoming a little bit more difficult at home. So firstly, if you have had a carers assessment or if there's been a needs assessment for the person living with FTD, and if things have changed significantly since that assessment, then we might want to look at having another assessment in place to reflect the change in that person's needs, and also to enable us to put some additional support in place in the home. So we might look at increasing that package of care that's in place in the home. So Nikki really wonderfully covered some of those first things that we might look at. We might initially start with maybe one care visit or a few care visits a day, but we might find, for example, that things might become a little bit trickier during the night time. So the person with FTD might be waking up during the night, they might be distressed or confused or agitated, and they might just need a little bit more support during the night time as well. If that is happening, we might want to take a look at having some care in place specifically during the night time. And that care might be something called sleeping nights, where a carer comes into the home and they have a bed to sleep in, but they are available in case the person with FTD does wake up and does need some help during the night. Or if the person with FTD is consistently waking up, if they are distressed, if they're needing help with things like difficulties with walking, or if we have some worries about their safety during the night time, we might then look at having waking nights in place with a carer there awake during the night to support them with that. So we might start with having nighttime care maybe once a week to begin with, or a couple of times a week, and that can be really helpful, particularly in terms of just getting a bit more rest if you are caring for someone with FTD, because we know that not sleeping well has a huge impact on people's well-being. So that can be a really helpful start with that. But we might find that that's still not quite enough support in place. And actually, as a care partner, you might need a bit more of a break in caring for that person with FTD. So it's really important to touch on here that people often speak to us about feeling really guilty, about feeling like they need to have a break in their caring role. But FTD is a really complex condition, and often the support that the person with FTD needs and deserves is too much for just one person to provide that support. So it's absolutely understandable and important for care partners to have a bit of time for them. And it's also a really helpful thing for people with FTD as well. So we might want to then look at arranging some respite so that care partners can maybe go away for the weekend or a bit longer, and maybe spend some time with friends and with family during that time. So as Nikki really helpfully touched on, respite care can look a number of different ways. So we might have a carer come into that person's home and support them there, or we might have the person with FTD spend some time in a care home as part of their respite. So in terms of arranging respite services. This will vary depending on your individual circumstances, but we might be able to arrange it through the local authority, so social services, and this might be part of a carer's assessment, making these arrangements. We might make contact with our local carers centre, who sometimes have specific funding available to support people with respite, or depending on our circumstances, we might privately arrange that respite instead. So in some cases, the person living with FTD might already go to a day centre as part of their routine, which can be really fantastic. And actually, sometimes that day centre might be part of a care home in terms of that environment. So it can be really helpful to speak to the care home directly to see if they do provide any respite services as part of the care home, because the staff may already be familiar with the needs and preferences of the person with FTD, which is really helpful. And also the person with FTD will be familiar with that environment as well, as it's already part of their routine. If somebody with FTD is having respite in a care home, we might look at arranging that a few times. And in some cases, this can be a really helpful way of trying out a care home if we are thinking about supporting the person with FTD to transition permanently to a care home in the future. So this can be a great way of having a bit of a trial run with this. So we might look at nighttime care, we might look at respite care, and we might still be finding things a little bit difficult at home, so we might still need a bit more support. In some cases, people might then have a live-in carer in place, which can be really helpful for some people. So it's really important to be aware that it can be a big adjustment having any type of care coming into your home, because that is your personal and your private space. And it can, of course, be more of an adjustment to have a live-in carer in place. So what we want to do is we want to make things more manageable for care partners, for live-in carers, and for the person living with FTD as well, in terms of that transition. So we want to try and fit with the person with FTD's preferences and usual routines where we can. And if there is a live-in carer in place, sometimes this can actually be a bit more manageable because we're not having to work around specific care visits to fit with that person's routine. It can sometimes feel a bit uncomfortable to begin with having a live-in carer in place because of your personal space and wanting to enable that. So we might want to look at ways of enabling a bit of privacy. So for example, some people might have a care cupboard or an area of the house dedicated to the care needs of the person with FTD. And what will be in that care cupboard will vary depending on the person's specific needs and preferences. But it might be things like photo albums, if the person with FTD likes to engage with this. It might be books about their areas of interest. So for instance, if the person loves cars, we might have lots of activities and objects related to that interest of the person. And we might look at activities that they engage with as well as part of what's available in that care area. We also want to work with the live-in carer to provide and create a really personalised care plan for the person with FTD. And as Livvy touched on, this is probably going to change over time as the person's needs change over time as well. So things that we might want to have a think about might be things like the person's usual routine. So for instance, do they prefer a bath or a shower? What time of day do they prefer those activities? If we're having any difficulties with supporting them to engage in those processes, How do we adapt those things to enable that to continue? We might want to think about how we communicate with the person with FTD. Do they have communication difficulties? And what strategies and adaptations can we put in place to support them? So for instance, can we have visual aids? Can we use pictures of places, people and activities to help with that communication? And finally, we might want to have a think about triggers that might be distressing for the person with FTD. So that might be particular activities, that might be noises or sensory input, or that might be kind of care routines and that side of things. So we want to think about ways of removing the triggers where we can. Not always possible to remove triggers, so we might also want to look at minimizing those triggers. And also we might want to have a think about how to respond to the person with FTD if they are becoming stressed by particular triggers. So we might want to think about things that are soothing for that person and redirection to different activities as well. So that's a great thing to work with the live-in carer to put those strategies in place together to support the person with FTD. So those are just a few things to have a think about if we are having more difficulties at home. Something else that we do often get asked about is when is the right time to decide whether someone living with FTD would benefit from moving to a care and nursing home or nursing home, and actually what is the difference between these two environments. So Trish, I wondered if you could help us out with this question.
Thank you, Claire. I think that was really helpful to look at the ways that somebody might be supported at home with more support needs. And we have to remember that some people manage at home for a long time, and it does depend on the person living with FTD, how they're presenting. It might be in some ways changeable. You might have times when someone's living at home and you're coping quite well, and times when you're not, actually. And that's got something to do with the fact that we're all human, and you might also be struggling with other needs yourself as the carer. We have to remember that carers also might have their own health needs or their own diagnosis, and so sometimes need more help. And so respite is a really good way to think about having some on-off hands-on support, really, and getting to know that respite can happen in care homes is a really good way to have a look at care homes. As Claire said, I think you were right, Claire, being able to go to day services or care homes for respite and ask questions, talk to people. Care is always about people. And in fact, making a decision about whether somebody moves into a care home permanently might really reflect much more on what you know about care homes already. You know, the thing is, people often don't know anything about care homes or want to know anything about care homes until they need one. And that can be a really difficult time to suddenly think, well, what am I looking for exactly? So if we move on the slides, I'm going to talk about maybe at that point, where do we go really? So how do we know when it's time? Well, I would argue it's time. Sometimes more importantly, it's when the carer says it's time. You know, you're the primary carer, you're the person doing this. And if you can't do this anymore, then it's time. And I think listening to yourself as the carer is really important. Sometimes, of course, that time is taken out of your hands. In other words, the person living with the diagnosis of FTD might have another health issue or an issue that happens and ends up going into hospital. And sometimes the hospital feel it's unsafe to discharge that person home again because their needs are so high. So sometimes the discharge team at the hospital might think, actually, this person they need more care. They need more professional care, if you like. So they may advise you and get some help off a local authority to discharge. Usually within a hospital, there'll be a discharge social worker involved to do an assessment. And sometimes it's that time when the carer, you might discuss with the hospital a plan and say, well, actually, I'm not sure I can cope at home anymore. I feel that this person is not getting the help they need from me anymore. I think maybe they need to go somewhere where there's more staff or more help. And sometimes that's a good time to see a transition into a care home. it can also be taken out of your hands because of a more serious incident. And this is unusual, so we don't want to presume this to happen to people, but it can happen. And I think it's important for me to say this here, is that sometimes because of FTD and the nature of the diagnosis, people might behave in a way that puts themselves or others at significant risk. In which case it might be decided by you having to call an emergency service. You might have decided that you need to call the police because you can't find your loved one. Or it could be that your loved one is in the community and someone else has called the police because they don't understand the person's behaviour. So if the police get involved, sometimes the person might go through a process of something called sectioning. And it could be that it's decided by the police, the local authority, it will be a social worker as well, and a health professional. There's 3 agencies involved in any sectioning. But once those 3 agencies are involved, it could be decided actually that the person must be detained within a section ward. Now that can sound like an absolute disaster, but it's not always a disaster at all. And a section ward is sometimes a really good place for a person to have a full assessment and then get the care that they need from that assessment, where they might be moved out into the community, into a care home, and that might be on a section 3. And in many ways, you know, we've not mentioned anything here about money. You know, all the way through our talks, it's, you know, the truth is if you're comfortable for money, an awful lot of this planning is really possible. If you're uncomfortable and you don't have much money, the fear of asking for care isn't just perhaps that you feel that you're not doing the job yourself, but also the fear of how do you pay for it? Well, the truth is if somebody goes through the section situation, which isn't ideal, but if they do, and they are discharged into a care home on a section 3, it will be fully funded by the NHS. So we mustn't only see that as a disaster at all. And often people can be really calmed down and supported through psychiatric support within the section process. But if that doesn't happen, but you're not coping at home and you know you're not coping, you can feel that every day you're waking up going, I can't do this today, I can't do this anymore. Well, that's the right time. It's the time to say, I need to think about a care home. Now, if in the past you've already used a care home for respite or had some relationships with care homes going to an attached day centre, then you might have some idea on the ones to look for. But if you haven't, let's think about what care homes might look like. Essentially, when we think about a care home, we sometimes think, well, what's a care home and what's a nursing home and what's the difference? There is a difference. They sometimes look the same, though. They really can look the same, but there is a difference, and it is a very specific difference. In a nursing home, a nurse must always be on duty. And if it's a big nursing home, there might be a nurse on each floor. So if you've got 2 or 3 floors, there might be 2 or 3 nurses, 1 per floor. Essentially, a nurse will then be the person that manages the person's care planning. Usually they manage the service in that they manage the shift, and they'll be the person who always does medication and thinks about other health needs. So if your loved one living with FTD specifically has other health needs, such as maybe advancing issues around diabetes or maybe some heart conditions or anything else that we can also become sick with, then a nursing home can be a really good place for them because there will be a nurse on shift that can manage their health needs as well. And the healthcare assistants or the care workers, they'll often look a bit nursey. They might have a nurse's uniform or a similar uniform. They're not nurses. They're not nurses, they're care workers. There'll be 1, maybe 2, if it's big, very big, maybe 3 nurses on shift, but often it's 1. And you'll often be the person that speaks to the nurse as a carer. The nurse will feel like the person you go to on shift to ask questions. So sometimes you don't get to know the support staff as well, actually. So when we think about a care home, what's the difference? Well, there are no nurses employed on shift. Having said that, there are ex-nurses and nurses who may have, you know, qualified overseas who don't work as a nurse here, who might work in care homes. So it does happen that nurses work in care homes, but they're not employed as nurses. And so everybody in that care home is involved in managing the person's service, and they're all trained in giving medication, and you'll have key worker systems usually. So you might speak to a specific care worker who is a key worker for your loved one, and you'll have deputies and managers to talk to. A care home might still have staff that look a bit nursey, quite often uniforms are quite nurse-like. They're often not, and certainly in a care home, they're not employed as nurses. So they won't be thinking about health needs in that way. Having said that, lots of care workers are extremely good at managing people's health, very good around medication, very good around, managing people's health needs. And they also can link very well into the local community, as you do when people live at home. District nurses, community team, and of course, GP, who will be allocated to a care home or a nursing home. It used to be that you could continue to use your own GP when you moved into a care home, but I have got to say more and more as time has gone on now, mostly the care home has a GP that comes usually weekly, and that happens in a nursing home or care home. And they'll usually come weekly, and if it's noted by the nurse or indeed the shift leader in a care home that somebody has a health need, they'll visit them in the care home. So it can work very well. You get very good health support when living in a care or nursing home. So sometimes the reason you might choose to support someone to move into a care home could be because you're not coping, or it could be that they need more health support that you can't really manage at home, or you're nervous and worried. You're lying next to them in bed thinking, are they going to be all right by the morning? I can't sleep because I feel that they're not well. And if you're constantly worried that someone's not well, that's another really good reason to think about a nursing or care home, because they can get really monitored 24 hours a day. Because the reality is, if you're the primary carer living at home with your loved one, you have to sleep. The truth is, in a care home or a nursing home, someone is always awake. So that could be a really good reason. It might be you're worried about another health need, not just the FTD. Could be you're worried about their heart or something else. So that could be a really good reason. It could be that generally the risks are increasing and you're just not coping with the risks at home, and it's been decided between you and possibly some other family members and maybe the GP. You might be now at the point where you're saying, actually, there's just too much risk now. Now, sometimes when we're feeling a bit forced to go toward a care home, there's a feeling of guilt, and some people might suggest that in their life with their loved one, they've said, I will never let you go into a care home. I promise to look after you forever. Well, what do we mean by looking after someone? I would argue that actually promising to care for someone forever does include a care home. It is actually more negligent not to use a care home sometimes, to say, I've promised to look after them, so I will do it at home. Badly, not with safety, actually causing more problems than maybe they would have to go through if they were in a care home. And in order to care for them within our promise, sometimes the best thing we can do for that person and to fulfill our promise to look after them is to find a care home. It's exactly what they need, and it's what you need. So then you can continue to think about, okay, care home options. Well, sometimes if you're involved with the local authority or the person's been sectioned, you'll find that professionals will help you find a care home. But if you're self-funding completely and you're independent at this point from those type of services, you'll be looking for a care home yourself quite often, though the local authority might help you. So it's worth contacting them. Try and get lists. Try and find out locally from the carers hub if anyone else has seen a care home. Speak to others about care homes locally. See what you can find. Visit them. See what the policies are. Have a look at them. Do you want something small because you feel that the person living with FTD would like that intimate space or small space? Or do you think that your loved one needs big grounds where they can walk that are secure? So think, what are the needs of the person? What do they like? Are they walkers who need to be outdoors all day? Well, think about the gardens and the space. If there's somebody that tends to want to sit in their room, look at views. Do they have a nice room? Are they good size? Think about activities. Are they a care home that has a lot going on? You can usually tell that by the mess of it all, really. Sometimes a care home that has a lot going on is a bit higgledy-piggledy and messy, and the activities rooms full of stuff. I quite like that because it means things are going on. Lots of stuff, lots of activity, a notice board, action. And you can ask, what happens here? And how does my loved one get involved? How do we make sure that my loved one is going to be involved in the choir or in any group that's happening, or any visitors that come, or any art workshops? How do you help them get involved? These are the questions I would ask. If they stay in their room because they're quite apathetic, how are you going to help them get involved? What do you do to get them down to the garden to do some gardening? That sort of thing. You might ask those questions. You might also ask, and this is really important when we think about FTD, how are you going to manage challenges? And I use the word challenges as another way to talk about behaviour. If the person with FTD is challenging, angry, and perhaps shows some of their needs through demonstrating anger, ask the care home or the nursing home how they expect to respond to that. Look at the policy. Think about who is going to move into a care home, what it is that they need, and then visit 2 or 3 care homes and try and tick some boxes. Not all care homes are going to be perfect. They're not going to be perfect. Not all nursing homes are, but they're going to help you have a relationship with the person that becomes the visitor to the care home, that you might visit them daily. That's potentially an option. You definitely want to know what the visiting procedures are. Through COVID, they were different. I think that's starting to relax more now, but still some care homes might have restricted visiting. If you feel that the visiting is restricted, you might ask to become an essential care worker. And an essential carer means that you can be the one person named to visit as and when you need. That means that the whole family might struggle to go at the same time. So you need to talk to the care home about their COVID policy as and when it might happen again, another bout of COVID. What do they do during that time? It's worth asking. You know, the fact is, when somebody moves into a care home, it's not the end of the world. It's the beginning of a different life. The fact is, you can't, love is not enough when it comes to this point of dementia. You can't do all of this at home. 24-hour care has to be provided by care teams. And whilst you can sometimes bring that into your own home, and it works effectively, a living carer, sometimes they need a bigger care team, a tag team that can only be provided in a care home, particularly when risks grow very high. So thinking about what your person needs and thinking about what you can cope with, don't write off the idea of care home at all. It can be an extremely useful way to provide good care for the person that you love. Thank you.
Thank you so much, Claire and Trish. That was really comprehensive and some really good points for people to consider. And I think, it's some of the questions that I see coming in as well as also touched on some of these things that you've spoken really open about, but I'm sure we will explore these further.
So thank you very much to everyone. That was really extremely enlightening, and there are some sort of direct follow-ups from the questions to some of those things. So I think we'll go for those first. There's a sort of direct follow-up. A question for Livvy first. Where do I get my sunflower lanyard from?
Yes, very, very good question. So you can get sunflower lanyards available online. Something called the Hidden Disability Store. That is the main kind of giver of sunflower lanyards on there. So I would definitely recommend going to hiddendisabilitystore.com to get your lanyards.
Good.
What we will do is we'll send out resources with the follow-up email that goes out next week with the link. So it'll have lots of resources of things that we have spoke about today.
Great. Okay, so next one is really about a therapies assessment, and maybe to, well, I'll see who wants to answer this, but I'll take it to a wider question. How do I access a therapy assessment? The specific question is, how do I access an occupational therapy assessment? But perhaps someone takes, how do I access therapy assessments? My husband has recently started to have mobility difficulties, particularly getting out of bed, sitting down, but I'm not sure who to approach. Who'd like to take that one on? Livvy.
I'll get in there first. Yes, so I would strongly recommend going through your GP. So your GP is the gatekeeper to all therapists. So whether this is occupational therapist referral, a physiotherapist referral, You may also find that you can go through social services for an occupational therapy referral, although sometimes this might take a little bit longer, in my experience. I would strongly recommend, if people are going down the private route, that people look on the Royal College of Occupational Therapists to find somebody who is professionally qualified and is registered as a healthcare professional. And this goes for any private therapist that you're getting. Please do make sure that they have the correct credentials, and that they are part of an independent practice code for their practice.
Great. I think that's very, very helpful. So this is a good question. Maybe some of these may still sticking with you, Livvy. This is really a bit comes back to this lack of insight, and the question is, my husband refuses to pay for care as he doesn't feel he needs it. So that's part of this, what a bit about what you talked about not recognizing the need. How do I deal with this? We have this a lot, don't we? How do you, people who don't think they necessarily need the care, and dealing around that. So this is specifically around how to pay for it, but it's a wider question around people kind of refusing care or not thinking they don't need it.
Lovely. I'm happy to get us started, and then if other
Great,
people...
Livvy, I'll stick with it. Some of these are maybe for you first, but yeah, we'll anyone else can come in.
Lovely. So I think that it's important to think about when somebody's coming in and the care tasks they're going to be doing. It's very difficult to have no involvement with the carer at all, and then suddenly getting into a stage that somebody's doing very personal, intimate care, and this is the first time you've met that person. So it's usually good to have a very slowly approach, and to have somebody being introduced to the person with dementia as a friend, as a cleaner, as somebody who's around the house, who's visible, who's a friend, who's doing these tasks. It's sometimes important to talk about the benefits of having somebody in to do care tasks. So this could be, this would allow us to have some time to focus on doing things which you like, instead of me doing this. I mean, that we have more time to do these special activities together. Does anybody else want to come in?
I think, Nikki, we've talked a lot. We've met with families a lot and talked about the way the names and the things that we attach to this, and they're not necessarily the need to use the term carer, and we've talked a lot about getting personal assistance and things for people.
It is, using personal assistance. I mean, I would love a personal assistant. If anybody wants to get one for me, I'm really quite happy with that. But I think also, going back to what I was talking about within my talk, is when people don't realize that they need any support or refuse to have support, that help is for you as that caregiver, as that family member, and actually using that as, that person coming in, that personal assistant isn't for you, that isn't for your benefit, it's actually for mine. We need to pay for that for me. We need that. This is my sanity. This is my support. This is my luxury. If you want to feel it as a luxury, it's not a luxury. It's help that you need. So actually going down the route that this paid person that's coming in to do the ironing, that's making cups of tea and everything, that's not yours, mate. They are there for me. They are definitely there for me. So I think it is using proper terminology. Don't use the words carer or sort of paid help that's coming in for these things. It's actually introducing them in a very different way of, we need a different face in the house. Love you as you do. We've been married for 25 years and I really love you, but actually we could do with somebody else coming in here to a bit of extra sort of support, a bit of extra fun, a bit of extra companionship for me.
Great. Okay, I very foolishly somehow went back to my full screen, so I'm going to go back. Here we are. I'm back in. So a difficult question here: what percentage of people with FTD end up in a care home? That's a sort of difficult question. I think, Nikki, and I think you addressed this, and a few people. Of course. And Trish, maybe you I think you touched on this. Of course, as time goes on, many people will. It is very difficult to and Trish said this right at the end, provide the kind of care needed within home. And some people do that, but maybe Trish, you have a sense of perhaps reiterate some of the things I know you talked about at the end about that difficulty of keeping people at home.
Yeah, I hear you. I don't think we'll have figures here on how many or the percentage. I doubt very much. But coming back a little bit as well to trying to persuade someone to pay for care, because I think that's important, whether it's care in the home or care home, for respite, because, care homes can be anything. I mean, the lowest I'm hearing is around £1,000 a week, but it could be up to £3,000 a week. This is enormous amounts of money. And the person living with FTD, particularly those living with FTD who are extremely able, very much in control, but no insight into their own diagnosis, might be saying, I'm not going into respite for 2 weeks. That's going to cost us £4,000. Are you kidding? I'm fine. I don't need respite. And actually, that's a battle that's really difficult. And to be honest, in each family, that's going to be a different battle based on your relationship already, based on how you've already dealt with money. Do you have a joint account? As an example, if you've already lived a situation where all your monies are joint, you just need to continue to pay for these things and say, well, this needs to happen. I'm paying for it. But if you've had separate monies, this might be more difficult. So I guess, the truth is, if you are paying for respite because the person living with FTD, for instance, or paying for all the care coming into the home before the point of care home, the truth is, if you're paying for it all out of your money for the person living with FTD because they are refusing, keep receipts. This is, excess disability expenditure, and it's worth reminding yourself that this is a huge cost, and the cost might include more heating, more washing machine on. You might find you're using a lot more water. You might find that you're putting heating on a lot more because the person you're living with might have obsessions about keeping everything on. It's possible that the cost is huge. I would say from very early on, keep a record of what you're spending, because this can help when you're looking at a financial assessment later on down the path, which you might not be thinking about now, but I would say just keep those receipts in place, particularly if you feel you can't have the argument with the person living with FTD because they're not understanding that they have a problem. It's easy for us all to say, oh, we'll talk to them, explain. The truth is, they're going to say, I'm fine. I don't know what you're on about. I'm fine. So you need another way, and it might feel a little bit duplicitous, and I hope it doesn't. You can still tell the person, I'm paying for all of this and keeping records, just so you know in the future I'm going to be asking for half of this back, if it's huge money, particularly.
Great. Okay. I am going to move on to maybe some questions. Well, here's another one, a little bit about therapy. Now, we don't have Anna here today, but someone asking really about communication aids. So do you have any recommendations of visual aids? My mother is at home with us. My father is a primary carer. I've moved back to help. Her speech production problems are very severe. She can read and identify pictures. I've recently printed off some picture cards. Do you have any suggestions of resources? Well, we don't have Anna, our speech therapist, with us today, but Anna and Neil would have lots of ideas. Does anyone want to?
Claire will be good for this one, I'm sure.
Claire.
She's our resources queen.
Absolutely. So I think firstly, it is important to see whether the person who asked the question, if you're able to get a referral to a speech and language therapist. So we know that does differ depending on where people live. So asking your GP about a referral is a really good place to start. And John, as you mentioned, we do have the lovely Anna Volkmer, who is a part of our team, who can support local speech and language therapists to strategize and have communication aids specifically when we're talking about people with FTD and their specific needs. In terms of specific communication aids in this situation, it does differ quite significantly from person to person. So it is about adapting to that person's specific needs. So some people find it helpful to have a calendar on the wall, which might have the activities for the week or even for the day if the week is too much information, and having pictures of those activities. So for example, this person is coming to visit, here's a picture of them, that can really help people to orientate to what's happening. But definitely, I think the main recommendation would be to have a speech and language therapist to look at the person's specific needs, as it does differ from person to person.
Great. Yeah, I think it's, I've just come back from a big meeting on FTD, and actually it was very good. There was a real good meeting of speech therapists from around the world to talk about trying to improve access to speech therapy for all people with FTD. And I think there's a real movement to try and get people. I think people underestimate the importance and the need for speech therapists. So that's something that's going to develop over time. So any information on managing symptoms of FTD in relation to driving? Who would like to take the driving question?
Claire, do you want to go with that again, because you've been dealing with this a lot recently?
Yeah, so I think that is a really helpful and important question to raise, and really important to highlight that lots of people have difficulties with the transition for people with FTD to stopping driving. So that is something that can be really tricky for a number of people. So really importantly, driving can be a huge part of people's independence, a huge part of their daily routine, and actually a really important social aspect for people, which makes that transition even trickier for people. And people in the early stages of FTD might still be safe and okay to drive, but it is really important to let the DVLA know about their diagnosis and the insurance company know about it as well. And a general approach is to try and gradually transition to supporting that person to stop driving over time, because it's much harder if one day we just say you can't drive anymore, because that's a huge change for people. Something that makes it trickier in FTD is what Livvy really helpfully touched on. People might not have insight, so they might not actually be aware that their driving is becoming impacted, and actually that they may be a risk to themselves when they're driving and to other people, in which case it might be somebody else's decision when that person with FTD needs to stop driving. So that might be a healthcare professional, it might be the DVLA, might do an assessment, and it might come out of that the person is no longer safe to drive. Or often what happens is it might be family members or people in that person's circle who actually have those concerns around the driving. So what we might want to look at is adapting people's routines in terms of driving. So sometimes people put together kind of a tag team of the care partner, of friends and family members who can support that person by driving them to the places that they like to go. So that becomes part of somebody's routine. And there's also community transport available in a lot of areas as well. So that's a great thing to look into. But just to emphasize that it is tricky, and we know that it's tricky. So if it would be helpful to have more of a conversation around strategies, then the direct support team would be really happy to support with that as well.
Yeah, it's very difficult. I think, we do our best to think about how people can drive early on, but as you say, it's not particularly early on, it's not something that necessarily needs to stop straight away. It's important to work out what that transition is. Great. We have a question which I always find difficult, which is a little bit about stages. So it says, my husband was diagnosed 2 years ago with FTD, been in a care home for the past year, decline in his ability to communicate, needs help cutting out food and eating, can't get out of chair with help. Is it possible to tell me what stage of FTD he is at now? I have a very simplistic view of this. There is no good staging system that's ever been developed for FTD. And the reason partly for that is because it's quite a variable illness. It's variable in terms of the length of the illness from start to finish. And at the moment, we're not very good at individually predicting that. So I think of this in a simplistic way. There's a very mild stage, which is when nobody would notice there was anything necessarily wrong. There's a mild stage where people will notice things, often maybe family and friends will notice that behavior or language or symptoms are different. And then really there's a moderate stage where things really start to pervade life and start to affect things. And really behaviors and language really start to affect everything that's going on. And then sometimes I think this the transition to the more, what I would call severe stage, is when people really need some help with their day-to-day function and daily activities of living, and people need more help and more care. And then there's a more advanced stage where people really need help with everything. That's a very simplistic view of things, but I think that in some ways that's helpful, because it's some of that transition is about the kind of help you need and the kind of people you need to see along the way, and there's nothing more clever than that in terms of really a staging. So needing help with things puts you into a much more severe stage. The difficulty, of course, is the question behind that, I think, is, well, how quickly will I change from one stage to the other? And that's the part that we're not good at. And that's the part that we're not very good at predicting. And while this is a progressive condition, you know, undoubtedly we see people that stay in one of those stages for a long period of time. And, you know, knowing that you're in one stage isn't great at predicting the time at which you move on to another stage. So it is difficult. I understand the need for people to feel that they know about what stage things are on, but it is very difficult on an individual basis to be able to predict when people will move from one stage to the next. Don't know if other people have any thoughts or comments about that. Nikki?
I think what is really useful for people to do is with their loved ones, is to make sort of 3 lists of sort of activities and tasks that people are really struggling with, so they identify that. And then with that task, a list of things that people can do, but would need a bit of assistance and support with. And then a list, which is quite a positive list, of things that people can still do really quite happily and independently. Yeah. And I think it really then, it can help them with their every day-to-day sort of living of, this is really easy to do, we can do this together. This is something that I need to add a bit of support on, and this actually is really difficult. And if we go down this route and expect somebody to do this without any support, it's going to be quite confrontational. So I think it's quite a good way of actually not seeing what stage people are at, but actually what their ability level can be.
And I was going to say, if that's all right, John, and correct me if I'm here, John, as well, I might be wrong, but I think sometimes what can be really helpful for carers or the person living with a diagnosis, if they're interested to do this, is to keep some sort of note, a bit of a journal or a diary to look at the trajectory and think, well, when did things start happening? You might have to look back for that, a bit of hindsight, you know, that holiday that was a bit strange, and start thinking about what a person's doing now that they couldn't do or they wouldn't dream of doing, more to the point, you know, what's the changes and how have they progressed over the last few years or months? And then you can sometimes keep a tally on how quick things are moving. It's difficult to look back, really. I don't know, but I think that might be an idea.
Yeah, I think that's right. I mean, I must say, I often it can often feel that things are moving quickly, but in retrospect, the recognition that things have been going on for quite a number of years, one realizes actually it has been a rather slower change than sometimes it can feel, I think. Okay, there are a number of questions about medications. So one of the questions is, my wife's been prescribed sertraline. Is there anything better she can take? The other one says, my partner is on fluoxetine as well as olanzapine and lorazepam. Is this common for FTD? And then there's a question about medication for sleeping So I'm going to come back to other people's thoughts about sleeping, because sleep often, medication isn't always the best thing for sleep. So, but we'll come back to that. So sertraline and fluoxetine are all part of a same group of drugs, which are a group of drugs that were partly developed as antidepressants, and they're all drugs that affect a particular brain chemical called serotonin and increase that level. And they probably do other things as well, but there have been a number of relatively small studies showing that this group of drugs that increase sertraline can have a very mild effect in a group study on modifying different behaviors. There are not many studies, they're relatively small studies, but there are a number of studies that are positive on a group, in a group basis. And so usually we would offer and trial a drug from within this group to see if that helps with things. The second reason, of course, is that many people, for reasons, understandable reasons, are also depressed, and depression can present in a slightly different way when you have dementia. And we have an incredibly low threshold for trying to treat coexisting depression as well. And sometimes it isn't always obvious when somebody is got coexisting depression. So really, there are two reasons why one might want to try a drug within this group. They are relatively well tolerated in terms of side effects. Of course, with all drugs, people do sometimes get side effects. There's no great evidence that one of them over another will be any better. So whether that's sertraline or fluoxetine or another drug within that group, there's no great evidence that one of those over another would be particularly better. Usually, what I would usually suggest to people is that one trials that, one gets to the right treatment dose and trials it and see whether there is an effect. And as I say to all people, drugs are always trials. They're always there to see whether there's an effect or not. And if there isn't, then there isn't, and there's no need to carry those things on. It becomes a little bit more complex outside of that group of drugs. Drugs that are given outside of the SSRIs are really given on the basis of evidence of, really not evidence of drug trials, but evidence of individual use by doctors. So often in dementia in general, people are given drugs that are similarly given to people that have a so-called psychosis, so have behavioral problems, or which may be a whole set of things. So drugs within the group, like olanzapine, often are given. Our suggestion is that those things should be done on an individual basis. There's a risk-benefit ratio to those things. There are risks to being on them. Again, these things should be trialed. If there is benefit to them, it's a very individual decision. And by and large, we do our best. I do my best to try and avoid those medications when possible. But of course, on an individual basis, sometimes those things are needed, and one needs to have a very clear thought around what the benefit is of that over the risk, and for that to be continually reviewed. So those things are a little bit more difficult. Anything outside the SSRIs is a little bit more difficult. In terms of sleep, sometimes people do use the drugs like lorazepam, or in the drugs that are the benzodiazepine groups. Those drugs have been used for many years as sleep medications, but by and large, they were replaced as sleep medications by the group of drugs known as the Z drugs, so things like zopiclone. But each of those drugs has its own limitation. They can help you get off to sleep in a short term, but they can't keep you asleep. They're only really for short-term use, and they don't have great evidence in any form of dementia. So any drug like that should only ever be used in a relatively short term. They shouldn't be used in the long term. And they're not going to be, if the problem is staying asleep rather than getting off to sleep, they're not going to be very helpful. Sometimes there are some medications now which we often use drug mirtazapine, which sometimes can be helpful in a very low dose to keep one asleep. But again, these are often really for short-term use. The other drug that's sometimes trialed in dementia, again without much evidence, is the natural occurring hormone melatonin. Again, it's a relatively side effect-free drug, but there's very little evidence for any of these things from drug trials. So again, as always, these things should be trials. They should be used in short term. There are some things which are better than others, and really should be an individualized decision on the things to try. Having said all of that, there are plenty of other things that are non-drug related, which can be thought of around sleep. Who'd like to
Then that's
Livvy?
Yes, thank you, John. So I'm going to split my answer into some sections. So thinking about strategies for sleep. First, during the day, getting exercise. So getting exercise, getting moving generally helps with your sleeping at night. Also really important to take into consideration that natural light aids the body's natural day-night rhythm. So try to ensure that the person with dementia is getting adequate natural light by spending some time outside, whether this is going for a walk. Unable to do that, then thinking of, sitting near a window. And this is particularly important during the winters. We're seeing now that it's getting darker a lot sooner, and also providing adequate lighting, either artificial or natural, throughout the waking hours is important. During the evening, I would discourage sleeping or dozing in an armchair if possible in the evening before bedtime. Try and keep sleep for the bedtime. Don't give the person living with dementia too much tea, too much coffee, other drinks containing caffeine. Thinking of only having a light snack for supper so your stomach's not really concerned with digesting that food. And don't give them alcohol to drink it to aid sleep. Usually it does the opposite. Same if they're a smoker, try to discourage him or her from smoking during the evening, and doing so just before bed. Also think whether to have a conversation with a GP, because sometimes some medications can cause sleep problems and sleep disturbances. So it could be due to medication. And then finally, very quickly at bedtime, try to establish a very regular routine, use regular bedtime cues, such as having the news at a certain time, turning off some lights to signal that it's time for bed, or use this familiar routine. Make sure that the bed in the bedroom is a very comfortable area. It's not too cool, it's not too warm, it's a very inviting area. Discourage reading or watching TV in bed, and keep these activities for another room. So keep the bedroom for sleeping, and try to maybe play something like soft music if that would help. But any other suggestions, really happy to talk about this further, because I could talk about sleep strategies for days, but I'll finish on that.
I think it's very difficult, isn't it? I think all of us, even in the general population, don't do all of those things which are helpful for us to get us off to sleep. And of course, as you hear from all of us all the time, it is as important for the carers to get good sleep and to have good health as well. So, thinking about your own sleep hygiene, and it can be very tempting to look at your phone as you go to bed, but those things are not good for all of us. So a couple of last run-in just in the last few minutes. Question: my wife is asking if there's a cure for semantic variant PPA. Can you tell me if any progress has been made? So I think always difficult. There are no cures for this group of illnesses. I suppose the good news to say is there are trials starting in these illnesses. Trials, though, mean are always going to be some time away from a treatment, even if a drug works. So there is a trial now started in the US for semantic variant PPA, but it's only just started. It's going to be a number of years away from knowing whether that drug works. And then, of course, as that drug becoming available. So it's always difficult. I don't think we are near a treatment for it, but it is always good. The plus side is that there's good news that there are trials happening in these conditions, but one has to always temper that with trials take time. We never know that those first drugs that go into trials are going to work. But I think good news that there are some trials now happening, or a trial at least, in somatic PK. And then perhaps we'll finish on just a quick question about powers of attorney. And the question is really about whether one needs to prove that their mother lacks capacity before enacting the power of attorney. Who would like to take that quick and difficult?
Send that to Trish.
Trish.
Okay, yes. With the financial power of attorney, that can be enacted any time, and the person can have full capacity and decide they're fed up with dealing with finances, and you can take on that task. And with FTD, that can be very helpful, actually, if you can persuade the person to let you take on that role. And that can happen anytime, but it is only when it's agreed from a health professional point of view, really, that the person no longer has capacity to make their own health decisions, that the other power of attorney, the health and welfare, this is the power of attorney that only is enacted really when it's agreed by doctors, or somebody in a health situation might say, well, this person clearly doesn't have capacity now. Then they start to speak to the power of attorney, then it's enacted. That might also include general welfare. So living in a care home, the person who might need some help with decisions about what to eat, what they like or don't like. It is only when and if and when they lose capacity that the power of attorney starts to make all those decisions in their best interest.
I think the difficult question, Trish, that is asking, I didn't put it to you very well. It is really getting a doctor to understand that someone with FTD does lack capacity at this point, and the complexity of having FTD when people, perhaps somebody, a GP or a specialist, doesn't quite understand the nature of the lack of capacity, and some advice about what to do in that situation.
Well, I think this is probably the $1 million question around capacity and FTD. When somebody lacks insight, also has a lot of skills, doesn't have your usual with dementia memory issues, potentially, still can do a telegraph crossword, but is making outlandish decisions, particularly potentially about money or other things that might be seen as exuberant, like sex or food, or things that become over excitable for the person who could be spending a fortune. And yes, everyone around them might say, but they've got capacity. So I think we need to be working hard at RDS, and we are, to raise awareness about FTD and its symptoms. So getting some evidence from the person's neurologist, asking to get information about FTD to the health professional. Not every health professional will know about FTD, or indeed a social worker, and saying actually they do look and seem like they've got capacity, and in many ways they do, but in deciding whether to buy a yacht or not, really they don't have capacity. So you're probably going to have a bit of a battle at times, I think.
I think the answer to that, and it's a nice one to end, is the benefit of the RDS and your support. I know that the team will help support, and maybe that individual person who's having trouble can, if they haven't already been in contact with the RDS team, can talk to them, and there are lots of resources and help that the team can provide in these individual situations. And I saw there's one other question where, Millie, I know you've directed an individual question. So if there are very personal questions and individual things that people don't feel they want to share with the group, or feel that they're very individual to them, as always, please contact our team, drop them a line. People are always happy to chat through individual situations and things that we can help with. On that note, I would like to thank all the team, so Claire, Livvy, Trish, Nikki, and thanks to Millie as well, for helping with today, and Leisha, and thank you to all for attending. Hopefully next time we will see you all in person in March, but please be in contact with us in the meantime. If you need to, we're always happy to have suggestions. So if there are suggestions for things for us to cover in the March in-person meeting, please do drop us a line, and please let us know. In the meantime, take care, and we'll hopefully see you all soon.